So next speaker will be Dr. Hans Kreder from Sunnybrook Hospital in Toronto, one of the seats of historical pelvic treatment. And he's going to talk to us about kind of a specialized fracture configuration that may require some different thought processes. So, Hans, I'll turn it over to you.
Great. Thank you. Greetings, colleagues and friends from Toronto, where it's nice and sunny. This is a fairly quick case to go through because I just wanted to make a few points. Most of the fractures that you'll operate on in the pelvic ring are for instability. That is, the pieces are moving, you have to stabilize them. This is a bit of a unique case that isn't a case of instability. It's a case of deformity. So this is a 26-year-old. She was on the back of a motorcycle that her boyfriend crashed. She ended up falling over with a motorcycle. Just have a look at her clinical photos there. The burns on her ankles are from the tailpipe of the motorcycle. And just think about which side you think is the problem side. She doesn't have a lot of pain, and if you examine her pelvis, it's really quite stable. You can crank on it and it doesn't really move. She really isn't complaining much of pain, and there are her clinical photos. And if you look at the spine, it looks like the pelvis is fairly, it's a little bit rotated, but it's not as rotated as the hemipelvis on the left would indicate. That hemipelvis is really quite significantly internally rotated. She's got parasymphyseal fracture on the right, on the opposite side, and a high pubis fracture on the left. And, when you look at the level of her hip joints, the left side is cranially displaced and clearly internally rotated relative to the right side. So in fact, if you go back to the clinical photo, it's the left side that's the abnormal side. It's internally rotated and shortened. And here are the volume rendered inlet and outlet views. You can see, among other things, some dysmorphism, but the important thing is the internal rotation of the left hemipelvis and the cranial rotation. So it's not a symmetric compression just from the lateral side. It's an asymmetric compression where the hemipelvis is rotated cranially as well as internally on the left side. And here's a representative cut on the CT scan. And again, you see the internal rotation on the left side. And I just want to emphasize that this patient's pelvis is clinically stable, the right side. Very importantly, you've seen, the last case where there were bilateral injuries. This right side is completely stable. She doesn't have much pain on either side. And when you think about this, here are sort of the thoughts that you might want to think about. If this was a geriatric patient with a stable pelvic ring, you might say, well, she doesn't have much pain. What's the downside of just having her carry on? Maybe restrict her weight bearing a little bit. And then, you might think about whether to reduce this deformity and to fix it and how you would do that. So again, here's the preoperative internally rotated and shortened left leg. And here is a picture from Dr. Tile's book on the pelvis. And this is called a bucket handle lateral compression, or this is one of the names that's been applied to this asymmetric type of compression. It's like the bucket handle goes cranial and medial, and thereby you shorten and internally rotate the leg. So here again, what's your management plan? My management plan was that I was going to reduce this short internally rotated leg on this 26-year-old young lady. It wasn't surgery for instability. She doesn't have any instability, but it was to reduce the deformity. So when you look at that, I'll just give you a moment to sort of contemplate how you might reduce that. And then once you reduce it, now the pelvic ring is going to have some mobility to it because you've taken it from a stable, impacted position. You're going to disimpact that. You're going to now have some instability, biomechanic instability of the pelvic ring. How are you going to maintain that reduction? So here's what we did. This is a clinical photo, and Sometimes you can augment that, and I usually try to do this before sort of prepping and draping, but you can augment that after you've got a bit of a reduction. You can augment it with some a fixation into the anterior inferior iliac spine and put a Shan's pin in there, 5 or 6 millimeter pin. It has to be quite robust because this takes quite a bit of force to reduce, and that can be a way of augmenting your reduction maneuver. And this is her, the pre-reduction and the post-reduction. This is before prepping and draping and so on. Just, you can see that certainly the rotation has been improved. Maybe she's still a little bit short. So this is the pre and post-reduction film. And my strategy on these is to distract with a fixator. Now, you can see that we've used bilateral anterior inferior iliac spine corridors and used a distraction type of frame there. And you can see that there's still some malreduction or incomplete reduction of that left hemipelvis internal rotation. Some people like to put a gluteus medius pillar pin in on the right, with the idea that that vector is more in line with the cranial displacement and the medial displacement. And I've done that, but I find the anterior inferior pins are a little bit more robust and a little bit more well tolerated by the patients when they mobilize. And I'll show you a clinical photo of this young lady in a minute. So that was my strategy, distraction. And I didn't think in this particular case that the disimpaction in this 26-year-old was going to be a big problem. But I'll show you another case here where this is a different case, much more significant injury. And and this is my case. This wasn't a colleague's case. This was my case early in my career in the first few years. And I recognized that I'd created a gap and that there was instability. I used that asymmetric type of, in fact, I just used gluteus medius pillars at this time. But you can see that that is inadequate fixation. If you do create a gap at the back there, you need to do more robust fixation than what was done here in 1996. And basically, this patient went on to a non-union, and I had to do a bone grafting and a proper posterior fixation. So be prepared for the creation of a gap. And if you don't fix that adequately, just like any gap in the body, it doesn't tend to heal very well. You risk a non-union if you don't deal with it. So in summary, a stable pelvic ring, one that doesn't move, may require treatment for reduction of a deformity. And this is one example of those. An asymmetric lateral compression type of injury can be quite stable and impacted. And the maneuver to reduce and fix that was described. And when do you do this? Well, for me, any clinically apparent leg length discrepancy or internal rotation, it's not going to get better. Remember that lateral compression injuries tend to get worse over time with weight bearing and activity. So what you see day one is possibly going to get worse. It certainly won't get better. So if you see anything clinically apparent, that should probably be reduced and fixed. And you need to distract it. And this is sort of the opposite of what we usually think about, but this requires distraction. And if you do that, just be mindful of a posterior gap that needs to be dealt with. And here's a clinical photo. She was upset that I didn't show her face. She said, "How's anybody going to know who I am?" And I told her that that was kind of the point of not showing her face. But here she is. This picture is actually not taken at 12 weeks, but earlier on. And I like to keep the fixator on if I can for about 12 weeks and then take it off. So that's the end of that case. Thank you very much for your attention.
Thank you, Hans. That's a fascinating case. We were just commenting, we always hear that term bucket handle injury. I don't think I ever really completely understood it till you explained it in these slides. So it seems like the thing that's unique here is that the contralateral SI joint is basically normal, and it's just crushed to the ramus on the opposite side, as opposed to a typical LC3 type injury where the other side may be open.
Yeah, and that term I think is Marv Tiles, the bucket handle. You know, he had that little drawing there of the bucket, and I think the lateral compression injuries are often not pure, you know, compression from side to side. They can go superior, as in this case, or in other cases, the asymmetry can be inferior. So you get medial and
Okay.
inferior asymmetry. So it's just one variant of that. But I think the important point is just don't forget about deformity. When the pelvic ring is stable, you still need to think about reduction and fixation for deformity.
And then Hans, one other question before we'll let Dr. Wright be getting his screen up to be ready to be shared here. But um, if the opposite SI joint had been open slightly, we still tend sometimes to use a distraction frame in the front. If you start distracting in the front to try to externally rotate the side that's internally rotated, how do you prevent that from externally rotating the side that's externally rotated? And does that require
Yeah.
some other
Well, you'll
strategy?
notice very quickly whether you've been wrong in your assessment of the opposite SI joint, because as you start distracting, it'll distract through the opposite SI joint instead of reducing the deformity. So if that's the case, then you need to have a strategy to stabilize that opposite SI joint first, usually with iliosacral screws. But you need some good fixation of that to distract against, or it'll just open up on the opposite side.
Great. Thank you, Hans. There's some questions coming through that I'll let you get busy trying to answer if you don't mind. But thank you very much. It's a great case and very interesting.